Afternoon, everybody. Adrian Hardy here again from the British Nuclear Medicine Society. I'm the patient rep, and today we're talking to Evelyn Bateta, who was giving a talk at this spring meeting in Glasgow on cultural competence. It wasn't recorded, unfortunately, so today I prevailed upon Evelyn to give us the bones of what she was talking about and how it's relevant to nuclear medicine. So, Evelyn, give us a bit of background about yourself, would you please?
Well, thank you, Adrian, for that introduction. I'm Evelyn Bateta. I don't have a nuclear medicine background. I'm a nurse by background. I have, however, worked with colleagues from the nuclear medicine background as a clinical nurse specialist for breast cancer and head and neck cancer. I have been qualified for 15 years. I have experience in so many environments in nursing, including cancer, surgical. I've been a nurse practitioner. Currently, I'm not a nurse in my role, but still I am registered as a nurse.
Right. So I think the talk you were giving was called cultural competence. So can you define what cultural competence is and why it actually is relevant to us?
Cultural competence can be described in so many ways, but in a nutshell, it is about understanding other people's backgrounds, cultures, beliefs, wants, needs, and respecting, them in that way. So everyone's got their own definition of cultural competence, but in a nutshell, that's what it should be. That kind of respect of where everybody comes from.
Explain this to your colleagues when you're saying to them you need to be culturally competent, culturally aware. Give us a couple of examples of the impact of how that would impact on their daily sort of relationship with patients.
So it is very. I'll be very wrong to say that everybody should be and would be 100% culturally competent, because the world evolves and the world is diverse and it's becoming a very diverse environment. But it's about having that open mind. To learn from other people, to learn from their backgrounds, to learn from their cultures, to learn from their beliefs, to learn from their wants, to learn from their needs. And then obviously in the patient's context, tailor make the care that you give to that person in front of you, to who they are and what their background is. So that is how I advise my colleagues to embrace culture and beliefs and where people come from culturally and in their daily life. So it is about having an open mind to understand the other person in front of you.
Right. And so obviously you've been putting this into practice in your own work.
Yeah.
So can you give us an example or two of how being culturally aware and culturally competent has made a difference to the way you've been able to encourage patients or deliver a service to patients which puts them perhaps more at ease or addresses some of the issues they may have based on their cultural background rather than the medical necessity of giving them a treatment at that time?
So naturally, I'm a very inquisitive person. I'm a history nerd, and I always want to know. I always want to know who is this sitting in front of me, and where do they come from. I mean, at the moment, I lead a team of I think there are about 73 individuals. However, 90% of that team is very diverse from different backgrounds. And every time I meet somebody, I always want to know, where do you come from? What kind of food do you eat where you come from? So in the context of patients, I always want to know. So, for example, if it's let me give an example. Last year, the year before, I was researching on prostate cancer among ethnic minorities, and I came across some Sikh gentlemen who I wanted to work with, and I wanted to understand what they understood about cancer. I wanted to understand, and if they did understand about cancer, how do they frame it? How do they deal with it? How do they approach it in their culture, in their belief? And the feedback was overwhelming. Some of them will tell you, we've never talked about cancer, we don't know about cancer, and most especially cancer in that context of a prostate cancer. And you learn a lot when you are talking to individuals. You learn a lot when you are inquisitive to understand where that person comes from, what are their beliefs, what do they understand with the problem that you're trying to address.
Yeah. So I mean, from some of these cultural and religious beliefs, then is there an unwillingness to accept that there's a medical cure, that they believe that either prayer or some other activity will resolve the issue for them? And so how would you almost broach the subject of, well, that may be the case, but you might want to try this as well, or how do you do that?
Very, very difficult sometimes. I'll give an example. I was a clinical nurse specialist for breast cancer screening, and I came across, I'll give you an example of two ladies. One lady was from Brazil, and she was diagnosed with cancer 3 years prior to when I met her, 3 or 4 years prior to when I met her. And the time she presented, when I met her, the cancer had metastasized. And she informed me that when she was diagnosed years ago, those 3-4 years ago, she went for alternative medicine because in Brazil, where she came from, they believe that alternative medicine is better than the scientific medicine. Another lady that I met, to my shock, was a nurse, a qualified nurse here in the UK, but she was from Uganda, and she was very, very religious. And she did say that when she was diagnosed, the pastor she went to advised her that he is going to pray for her and she is going to get healed. Now, this is a nurse who was practicing here in the UK. You can imagine my shock when I was talking to her, although I didn't show it in my face because I was feeling angry at the fact that she took that route, and I was feeling angry at the fact that she did not take the preventative measures. And now we're at the stage where we cannot do anything other than, she had become palliative. And talking to those two ladies, I kind of understood that it can be a little bit difficult to convince anybody that there is a cure there, or there is a scientific way of curing your disease. When somebody is set in their belief, it is very, very difficult. However, I have personally, my father started having symptoms of prostate cancer, urinary retention, infections constantly. This was in 2016, I believe. And it took me almost more than a year to convince him to go and get checked out. When he eventually went and got checked out, he was diagnosed with prostate cancer, although it was at a very early stage. Then he said he is not going to go for scientific treatment. He said he is going to go for alternative medicine. And it took me that, so he doesn't live with me. I made it my mission to call him almost on a weekly basis, and call him with facts, call him with scientific evidence. I made it my mission to research on that alternative medicine he was taking, and research on how many people have been cured with that alternative medication. And I couldn't find any. So I had to, show him that this is the fact. The alternative medication you're going for hasn't cured anybody. However, what I'm asking you to do has cured so many men. Eventually, he relented. He went, had treatment, had radiotherapy, had chemotherapy. He is fine now. He went on to have 3 more children at his ripe old age of 72. Oh. But as I was telling the colleagues at the conference, he became the only gay in the village. I mentioned that as a joke because he's now going on telling everybody how what I did for him was absolutely marvelous, and he's still here, whereas he's lost a couple of friends through that alternative medicine that he had gone to.
Right. So your father's one of these statistics about the more elderly fathers now, isn't he? The over 60s.
Yes.
Maternity has gone up a lot. He's responsible for 3 of them. That's pretty good going.
Yeah.
Didn't sell that as one of the benefits of going on this treatment, I hope.
Yeah, absolutely.
Yeah. So that just goes to show, even when you know the person well and they should have some trust in you, it's a long, hard slog. And I suppose then for a lot of clinicians, when you're seeing patients in the outpatient setting, you've got a limited time to see them in. And also, if they're not all that keen on it, they're going to be the sort of outpatient who doesn't turn up, and then they sort of fall out of your knowledge, don't they?
They do.
The basis they're not going to come, we'll use that slot for someone else next time. So there is that message about keep on reinforcing this. But given the time limits that you've all got in the health service and the queues of people waiting to be treated in a more positive attitude, is that not an issue in itself?
Yes, it is an issue, but I think we can develop ways of how to deliver these messages. So, for example, I've always looked at the leaflets that we give patients. There isn't enough on those leaflets. There isn't enough information. There isn't enough, if you do this, this is what's going to happen, and if you go this way, this is what's going to happen. There isn't enough information about, radiation is not equal. It is not equal, death, because in some cultures, most especially the people where I come from in Africa, radiation equal death. Radiation equal cancer. They're not going to go for MRI or a CT scan. For them, that's a no-go area. If you tell somebody, oh, this is how the PET works, we're going to inject you with something that's going to go through your bloodstream and then it's going to land us where the cancer is, that's going to be alarm bells. What's that you're injecting in me? If we have those better explanations that this is what we're going to inject you with, this is what it's going to do, it's not going to harm you in any way, shape, or form, then if we reinforce that kind of information, people will listen.
Yeah. Because there are some things like CT scans and MRI, which are all magnetic, aren't they? They're not actually it's only when you're doing the actual nuclear medicine scan you've injected an isotope to go around the body and identify the hotspot. But some of these other ones are perfectly, well, I say perfectly normal. They are just magnetic fields, aren't they? They go around the body in those really great big donuts you get moved through.
Yeah.
So it is then that message of getting across to people that the dosage of these things is low.
Absolutely.
That they are very much targeted on identifying where the cancer has spread to, and also they're enabling you to see when various sorts of ongoing treatment are actually going to be effective. I understand from some of the people we've spoken to that you need to perhaps get rid of some elements of obvious cancer before you can say tackle it in the bones, or some of these sort of the more specific radiation treatments that are coming up with the molecular radiotherapy and things like that require a lot of research into them, and also I think an explanation of the cost that's involved, because I think that don't all realise that some of these costs of six to £20,000 could be for a treatment. Got a course of 6 treatments. There's a lot of money being invested, and they need to be committed to it, don't they? To come in and have it. Which is why we were doing some of these talks, to talk to patients, to say, well, how was it for you? What were the benefits? What were your anxieties? So that is part of what these talks were hoping to address. We've got a few more patients, I hope, to be coming forward now to talk through that. But when you said to me earlier, you had done some work around nuclear medicine. How did you find that patients were very, very worried to start with about what does it mean? Am I going to go home glowing? Things like that.
So, like I said, I was working with as a clinical nurse specialist for head and neck cancer. Thyroid cancer patients take those radioactive tablets. So the first, I had one so many questions. So if I take that radioactive tablet, how if I'm walking around going home, am I going to be radioactive? If I get home, is my dog going to be radioactive? Is my family? Do you know what I mean? So it was all about explaining how this process is going to work, how long it's going to work, how long that pill is going to take in your body, how long it's going to take for it to be excreted, and how long you should be isolating from your family. It's just for precaution. It's just not that it's going to be radioactive, but it's just for precaution because you never know. I found it very beneficial for patients more so if you explain explicitly exactly what's going to happen from start to end. You can actually see it in someone's face that they had that fear initially, but after getting that understanding, that knowledge, you see the fear going away. And I remember I had that conversation. There's a lady who came from China. She had an interpreter. And I thought to myself, I did ask the interpreter, are you confident enough to interpret exactly what I'm saying? Because this lady had missed her appointment, I think twice, because she was scared to have that radioactive tablet. And the interpreter, she did say, yes, I am going to interpret everything the way you say it. I mean, it went very well because she went on to have the radioactive tablet, and she went on to get discharged and then put on the follow-up for 5 years. But for me, that was a lesson for me to make sure that the patient understands explicitly what I am trying to say to alleviate that fear.
Yeah. And I suppose also that's in part then talking about the home situation, isn't it? Because again, it's handy if you've got 2 toilets, for example, one that the person who's got the radioactivity excretion can use. And for blokes to sit down and have a wee, don't stand up, and put the lid down when you flush it. All these sort of basic things. But if you've only got a single toilet in a house and things like that, then again, people think, well, hang on, how are we going to manage this? Or you've got issues with looking after grandchildren. Again, it's to know how much that impact is, and I should say, be honest about it to start with, because if you know it's going to be radioactive for a couple of days, then you can make some alternative arrangements, can't you? Go and sleep somewhere else, or book a hotel room, or
absolutely
hospital or something like that, if need be, if they're that radioactive. But it is actually then wanting to know about every individual circumstances. Don't assume. You're saying don't assume anything, basically, aren't you?
Absolutely. And that when with all those patients, the first thing I used to ask is the home environment. How is your home environment? How many little ones have you got? Because I had a lady who had just had a baby 5 months. This is a lady from India. She had just had a baby. The baby was 5 months and she was still breastfeeding. And obviously she got diagnosed with thyroid cancer that needed her to have, the radioactive tablet. And we had to explore how this is going to be done. Who's going to take care of the baby? The baby needs to. We gave her time to wean off the baby from breastfeeding, so the baby can start being bottle fed. So when she comes back, she doesn't have to hold the baby. We went through everything step by step, and by the end of it all, I remember she did call. No, it wasn't her. The husband called and he said, you know what, thank you very much, because initially we're very, very scared and skeptical of how this is going to work, because obviously they had this 5-month-old baby who was still breastfeeding and they have no family here to help them. And the husband was, how am I going to do this with a, 5-month breastfeeding baby? So it was about, I had to go through to the maternity wing to talk to them, to get a midwife to come and talk to this lady, because I'm not a midwife. Yeah. So I had to involve a lot of people in the treatment of this lady to ensure that everyone around her and herself are comfortable and safe.
Yeah. So that again is leading through to the need now for multidisciplinary team discussions, isn't it?
Absolutely.
And it could be in some cases occupational therapists, things like that, or speech and language therapists if someone's got a thyroid or a neck cancer, like that. So that every possible avenue that you can think of that they might want to ask is actually being discussed, and you've got a specialist who can put some information into the discussion with them. Yeah.
Absolutely.
So yes, it's just reinforcing that message that the patient is there, but they do need all the inputs being fed into them in a constructive way, don't they? And no contradictory messages, because the worst thing that can happen is you tell them one thing and the specialist tells them another. Yeah. Or on the ward round, the doctor says something, the nurse misinterprets it, gets fed back to the families. Yeah. And before you know it, there's this whole issue about, well, which one is right? Do you know what you're doing? And that can destroy all the confidence, can't it, that people have got.
Oh yes, I have seen that happening, and I have a patient who so she was diagnosed with breast cancer, and she did not want her breast, as she said it, cut, and because she believed she's going to be disfigured. So I don't think the entire process was explained to her really well. She got to theatre with the rods that they put in the breast to start, and she did ask, okay, what am I here for? And they did explain, you're here, we're going to take these margins off, we're going to take this how many grams of your breast, and she said, no, this is not what was explained to me. And she literally got up, put on the gown, and walked off.
Right.
With the rod still in her, and they had to coerce her to come back. At least let's take this out and let's go back. And this is when I got involved. Okay, so what happened? What was not explained? How did we? What went wrong? I mean, for me, it reinforced that need for. This lady was from, again, a Pakistani background. Culturally, there's a way. She doesn't want her hair falling off. She didn't want chemotherapy. She doesn't want her breast disfigured. So it's going to take away her womanhood. Initially, we did not explore culturally where she comes from, her beliefs, her wants, and that is where we were when she walked out of the theatre, because nothing was explored.
After you'd had a chance to explain things to her, did she come back?
It took us a very long time because she was very, very traumatized, and eventually she did have the op, and she did not go on to have chemotherapy. At the moment, she's still there thinking of the next steps. But for me, I think we could have done a better job if we were culturally competent and aware of her needs, her wants, her beliefs.
Yeah.
We wouldn't be where we are now, where she still has DCIS in situ, whereby if we had explained really well how the treatment is going to go and value her, culture, belief, her wants, we wouldn't be where we are now.
Right. So, in some ways, that initial investment in time saved all the other follow-up issues that you've had with that lady, for example, and the time and effort that's cost, the anxiety it's caused for her. And I suppose bluntly, the aggravation some of your colleagues would have thought in the operating theatre, blimmin' heck, we've got her here. And then she just had the temerity to get up and walk off, which a lot of people wouldn't do. So again, investing that bit of time up front in the patient and explanation pays dividends in the end, doesn't it?
Absolutely, because if you think about it, that time that was taken to calm the situation it took them hours. So that theatre time, those are resources being wasted for an hour's talk that you'd have had with this patient initially, so that they can understand exactly how the treatment is going to be and what it means to them.
Yeah. So I suppose by way of, when you were concluding your talk in Glasgow,
yes,
what was your takeaway message that you left everybody with?
So my takeaway message was to, again, I'm going to go back to how I explained cultural competence, is to look at the person in front of you. Try to understand, be inquisitive, try to know them, try to gather a lot of enough evidence about their culture, their belief, their wants, their needs, how they envision this treatment to go. And if they envision it in a negative way, try to bring them back to that positive understanding. It is about looking at the person in front of you, because and making sure that you understand that every individual is different. We might look the same, but we are individuals at the same at the end of the day.
And is that equally true for the staff themselves? Because you all got cultural backgrounds, haven't you?
Absolutely.
And I suppose you may need to put some of your cultural anxieties or thoughts to one side, thinking, what is it that it's not what I'm thinking as the actual member of staff. It's what does the patient think, and not to transfer my anxieties or thoughts or restrictions onto whatever I'm going to suggest to them. It's actually what is it they are prepared to go along with. Yeah.
Absolutely. Again, I can go back to the lady who I've just talked about, the breast cancer lady. In that scenario, all of the staff around were very, very upset that how, they had never seen anything like that, because, almost everybody, 90% of, the women who get diagnosed with breast cancer, the first thought is get rid of this thing. Do you know what I mean? But you're always going to get that one person who doesn't want their breasts taken off. They don't want even a single bit of it taken off, because that is them, that's how they are. And it's about accepting that the person in front of you has got their own views, beliefs, and needs and wants, and you should respect that.
Yeah. Right. Well, I think there's a clear message there. Whether we've all got time to follow it, I'm not sure, but let's hope we do, because I think what you've explained is obviously so fundamental. I'm sure it should be taught. I'm sure it probably is taught at nursing school and taught for doctors in training. But I suppose once you're in the heat of your clinician's work, sometimes you get more focused on what is it the outcome I need for this person, as opposed to what is that the person needs themselves.
Absolutely.
And how do I tailor the treatment to actually fit in with their sort of, as you say, belief system or domestic circumstances and things like that. Yeah.
Absolutely, absolutely. And I think like you said, rightly so, we as clinicians, we always think that what we advise and what we think is always right. No, it's not always, because at the end of the day, you're not the one who's getting the treatment, it's the other person in front of you. So if they come to you and say, this is not how I want things, even though you believe this is the right thing for them to do, you have to honor that. Yeah. That is their wish.
Yeah. If you explain it to them what the downside is of not doing the treatment, as well as the upsides of having the treatment, and they choose not to do it, then that's the perfectly legitimate decision for them, isn't it?
Absolutely. So you just do your job, explain, give evidence, make sure that they understand. Now the rest, whatever they choose to do, it is up to them.
Yeah. Well, that's great. Evelyn, thank you very much for having a chat with us. And I shall make sure this gets online, and hopefully other people who actually take notice of what you're proposing, what you're suggesting from your many years of experience, actually sees better results for the patient, and a lot more, I suppose, satisfaction from the clinician's point of view as well, because you get the treatment they get the treatment they need, and you get the satisfaction of leading them down that path to where they actually make the right decision. So can I thank you on behalf of everybody who's going to listen to this for your time today and talking to them all in Glasgow, and many happy years of keeping on working. And
thank you very much, Adrian.
Thank you very much indeed.
Thank
Bye
you.
now.
Bye-bye.